Don't let my residents ever hear this.
It gets your mojo going.
It does. It's fun.
Probably be pig rimping.
It's a safe place here. We're in the trust tree. I use inhaled sildenafil.
We're smoking like around here.
Yes, we are.
Dangerously drinkable.
Actually, lucitropy is a thing.
Hey, alcoholics. Welcome back. This is Jimmy, and we are continuing on with our two-part series discussion with John Ryan on Brian's case that he had out in Rock Springs, Wyoming. Where we left off, he was contemplating what to do and how to best care for a patient who is hypoxic, morbidly obese, and with obvious right heart dilation. So as we see how Brian deals with this, ask yourself, how would you best prepare this patient for a several-hour transport in an ambulance? Would you anticoagulate him? Would you not anticoagulate him? Would you intubate him? Would you put him on BiPAP? Tough questions. So we'll see what Brian does.
So, leaving PAAT, or PAAT, Jimmy, which one is it? How many A's? And moving on to the 60-60 sign. So this patient did have mild tricuspid regurgitation. You can see at the top of the frozen continuous wave image on the left-hand side there, there's a little blue wisp in view. And you can tell from the background chatter that it's not a loud amount of regurgitation. I had to turn up the gain a bit to get an accurate representation of where the peak velocity was occurring. And maybe I gave him a few millimeters of mercury more than he deserved there. But in general, his gradients at maximum seem to be in the mid-40s, which is consistent if you'd seen an acceleration time of about 40 to 50 milliseconds and his pulmonary artery flow profile with something called the 60-60 sign.
Yeah, so the 60-60 sign is based on the concept that it is very difficult to, namely that the right ventricle doesn't tolerate acute increases in pulmonary artery pressure very well. So what you see is the following. Strictly speaking, it infers that if the right ventricular systolic pressure is less than 60, as estimated by the tricuspid regurgitant velocity, such as what you've done here, and if the right ventricular outflow tract acceleration time or pulmonary artery acceleration time, PAAT, is less than 60 milliseconds, then this infers that it is an acute pulmonary embolism. And whereas if the right ventricular systolic pressure is greater than 60 millimeters of mercury, most right ventricles wouldn't tolerate that, and therefore or acutely tolerate that, and therefore it suggests that there's a chronicity to it, either obstructive lung disease, left-sided heart failure, etc., and that is more indicative of chronically elevated PA pressures. However, what you're experiencing here really reflects some of the limitations of the 60-60, where first of all you need to be confident with your right ventricular systolic pressure, you need to be confident with your tricuspid regurgitant velocity, which has already been shown to be difficult in this person with this considerable abdominal adiposity. So there are a lot of assumptions that go into it. At its most reliable from a research standpoint, or at its most impressive from a research standpoint, is it appears to be more accurate and more specific than McConnell's sign. So that's probably where its best strength lies. McConnell's sign is this hyperdynamic right ventricular apex that you see in acute pulmonary embolism with some hypokinesis of the base, which is where TAPSE sometimes falls out in pulmonary embolism. And when compared with McConnell's sign, the 60-60 rule appears to be more accurate in diagnosing pulmonary embolism than McConnell's sign. So that's, I think, all of this, and at least, and I appreciate you inviting me on, because all that we're trying to do every time we see these guys is find how many clues you can possibly put together in order to come up with a unifying diagnosis. And you need to take your PAT, take your right ventricular systolic pressure, take your right atrial size, right ventricular size, and combine all of these things along with your TAPSE, along with the clinical history, to try and come up with an accurate picture, because none of these are absolute, unfortunately.
And do you have a distinction at all between using the 60-60 sign in patients with pre-existing, I guess I should say, is there much of a diagnostic separation in patients that you know have pulmonary disease in the past versus patients that are naive to pulmonary disease?
Probably, yeah. So I would think so, and I think that's where the basis of the 60-60 sign comes in handy. Now, but this gentleman, even without a clinical history of pulmonary disease, you know he has pulmonary disease. His BMI is 60. You know he's got restrictive pulmonary disease. You can say with marked confidence that he probably has obesity, hypoventilation syndrome, or some sort of obstructive sleep apnea, even if it's not diagnosed, even though unfortunately he's a young man. So that's what unfortunately will affect the accuracy of our 60-60 here. I would also add, however, that the right ventricular systolic pressure that we estimate on echo is just an estimate. And time and again, most famously by Jonathan Rich and others, we've seen that right ventricular systolic pressure are accurate to about 15 millimeters of mercury. So when you end up with this right ventricular systolic pressure of, say, for example, 55, that means it's somewhere between 40 and 70. And that's something that I think is important to take into account. The 60-60, and the way that I get people to conceptualize 60-60, Jimmy, is that I'm assuming that my pressures are about, as I said earlier, 20/5 in my right ventricle. And if my right ventricular systolic pressure was to go over 60, all of a sudden, with the drop of a hat, I would die. So I think there is some selection bias that people with pulmonary embolism who come into the emergency department, you're unlikely to see a right ventricular systolic pressure of greater than 60 in pulmonary embolism because they wouldn't have made it to your emergency department. They would have unfortunately expired on the field. So I think in order for your right ventricle to acutely adapt to a right ventricular pressure, I don't think you can acutely adapt to a right ventricular pressure of greater than 60, and that's what I think drives some of the value of the 60-60 rule. Now, if you're working on a background of obesity, hypoventilation syndrome, obstructive sleep apnea, your resting mean pulmonary artery pressure may be 35-40, in which case, if you were to have a pulmonary embolism, you could see pressures of 70-80 and actually be able to tolerate it just fine, whereas our right ventricles would not. So it all really depends on what your right ventricle is used to dealing with on the background.
And so now we're going to take a quick look at some chamber quantification. And I was interested in determining how much of a chronic component could this patient have. And a lot of my supposition in attempting to make these measurements was that if I'd seen a thickened RV, then that would provide me some evidence that there was at least a chronic component that I could justify. And it might look like I was kind of throwing you for a loop on the measurement on the left, looking at the RV free wall. But I think if you look at the parasternal long axis image on the right, you'll see that that RV free wall does appear rather thin, and the measurement of 0.39 centimeters would be consistent with a normal wall thickness in a healthy patient. So obviously you've brought up some concerns for long-standing remodeling and thinning of the RV free wall, which is something that I haven't been aware of in the past. And is that something you see frequently?
Yeah, this is a thinned out right ventricle, and again, I think the left ventricular hypertrophy analogy I think is useful because conceptually we're used to that eventually your left ventricle will burn out. So I think the presence of right ventricular hypertrophy does indicate a chronicity to it. However, the absence of right ventricular hypertrophy, the opposite is not true. The absence of right ventricular hypertrophy does not suggest that it is an acute process. It could be an acute process, or it could be a burnt out right ventricle. And actually, the prognosis from having the right ventricular thickness is not associated with does not have a prognostic input because of that.
So yeah, we could start here, I guess. So our TAPSE, our unvalidated TAPSE looked low. Our PAAT, if you believe the metric, was fast. Our 60-60 sign could have been present overall. And our RV chamber quantification reveals that we have a thin RV free wall and a dilated chamber. And so we're looking at a patient with an acute presentation of hypoxemia. He doesn't wear baseline oxygen at home. He's had normal saturations before. And the question is, what do you do? And so the question of intubation we'll put off because I think that's a bit more about RV physiology. Question of how do we address the diagnostics in this situation. So without any additional information beyond the echo, I would be uncomfortable. I would be really uncomfortable lysing this patient. In the real world scenario of this case, I did not lyse this patient. So And so I'm not sure if we discussed this already, but the patient's EKG demonstrated a sinus tachycardia with non-specific changes in the ST segments and T waves that were not clearly indicative of active ischemia. But at this point, when making these decisions, we got an I-stat troponin back on this patient, and it was indeterminate range for our hospital. It was 2.1. And so now I had a justifiable diagnosis of NSTEMI that was slightly down on my diagnostic pathway. And I thought it would be unlikely for this patient to have generated pressures such as he had in an acute right heart infarct. But truthfully, isolated right heart infarct isn't something that I've seen so frequently that I feel really comfortable making that assessment on pressure alone. And so with an elevated troponin, it was easy for me to convince myself that heparinizing was an appropriate scenario for this patient. And so he was initiated on ACS dosing of heparin. So my big concern in dealing with these patients is that they seem to be the most unstable patients that we confront in the emergency department. Despite this guy's normal blood pressure, when you're tachycardic to that degree, hypoxemic to that degree, and your right heart is not performing, you become the most high-risk patient that I deal with in a peri-intubation period, because I have the opportunity to completely tip you over the edge and push you down a pathway that I can't pull you back from. And so when we think about these patients, we like to think about how can we optimize the physiology of their right ventricular when it's failing, or the right ventricle when it's failing. And I kind of break it down into these three areas, and I'm not sure that I've really thought about it this way before. Clearly, preload and afterload are things we really think about, and pump function, gross systolic function, we have ways of affecting that. But I was curious to hear some of your ideas in a patient that presents with acute right ventricular failure who is in a state of refractory hypoxemia. What would you do to optimize these features? And before we go on from that, I want to just kind of point out that I've seen two propositions previously for preload and its utility in the RV. One of them would present with a Frank-Starling curve kind of like this, which is as you increase that preload, you're approaching a limit of cardiac output from the right ventricle, its ability to pump forward. But you don't really ever fall off this cliff, and it's akin to this bicyclist on the right-hand side of the screen where you can continue loading them up, and they'll keep pedaling forward and pumping out more baskets and moving forward with cardiac output. Whereas other models would propose that you have something more like this, where as you increase the preload or hand this guy more limes, eventually you're going to get to a point where he just can't hold all the limes anymore. He can't push it forward. And this would be really concerning, because if we were to flood a patient with right heart failure with fluids, we could potentially make them worse. And I'm curious, from a preload standpoint, do you think there's a sweet spot beyond which we could actually cause damage?
Yeah. I love the graphics, and I think they're quite insightful. Preload in the right ventricle is hard. And managing it is hard. There's, as you rightly said, there's this, perpetuated physiology about the right ventricle being preload dependent, and sometimes people get concerned about diuresing these people because in medical school we're told the right ventricle is preload dependent. You need preload and so on. A lot of that, again, is based on our physiology, that we depend on preload. This gentleman with the adiposity will have plenty of preload, so I would not be concerned about taking volume off of this gentleman, and that can sometimes be a concern that people have, in that in your chronic hypoxic, obese, pulmonary hypertensive gentlemen such as this, you are not going to, or at least it is unlikely that you're going to hurt them by diuresing them and getting fluid off. Now, it's kind of the opposite to what you're asking, is can you give this person too much fluid, and can you tip them over? And I think that is the case. The right ventricle does tolerate volume well, but I do feel that there is a tipping point where there is too much of it on board. So, but you're in a very difficult scenario. So I think a lot of this, none of this is going to happen in a vacuum. I think you're going to, if you are, for example, going to intubate, as you know, you're going to change the intrathoracic pressures. It's a life-saving scenario. This gentleman has already demonstrated that prognostically there are so many red flags here that it's going to be very difficult for him to pull through it. So I think what your approach of doing everything that you can to help this guy is spot on. And I think if you are doing intubations, I would just think that if you're also giving fluid to help support him, I don't know how necessary that is, but do think that you would then need to provide some other support for the right ventricle in either form of in the form of an inotrope, which is very different.
Which brings us kind of to our next point, which is RV squeeze, RV pump, so to speak. And we have a variety of options out there. To be honest, I don't know that I've seen dobutamine used very frequently in the emergency department, at least where I've practiced, and I could probably count on both hands the number of times that I've used dobutamine personally in the emergency department, and not exceeding that. Milrinone, I'm not sure that I've ever seen it used in our emergency department.
And I would like to add in that Milrinone will kill this guy, and there is, because Milrinone will systemically vasodilate him, and if you lower his systemic pressures, that is what's going to make his right ventricle collapse, because the right ventricular pressures are already elevated. You're not going to touch the right ventricular pressures with Milrinone, and they're already elevated chronically, as well as some sort of acute process that we've gone into, and by initiating Milrinone, the left side of pressures are going to go down, the left ventricular performance is going to go down, and as I go back to earlier, the right ventricular performance is so dependent on your left ventricular performance that this guy is going to hurt a lot when you start Milrinone, and that is a concept that is important. I think your epi and phenyl and so on, in order to try and vasoconstrict, is useful. What happens with the vasoconstriction, and there's some nice animal data for this as well, which does actually translate into human data, is that if you vasoconstrict and the left side of pressures go up, then the left ventricular performance goes up and your right ventricle will go up as well. So, and the most famous animal models for this is actually transaortic constriction, where you essentially create an aortic stenosis model, and your right ventricle in pulmonary hypertension, and your right ventricle will improve and prognostically will do better. And that's kind of what you're trying to do with your epi as well. So I do think there is a role for vasoconstricting as well as for inotropes. The dobutamine is many people, we've looked at this, and in pulmonary arterial hypertension, and dobutamine is the inotrope of, when you look at pulmonary arterial hypertension practice worldwide, those of us who run pulmonary hypertension centers, the commonly used agent to support the right ventricle is dobutamine, and 50% of people use dobutamine to support the right ventricle. This is in the ICU setting in right ventricular failure from pulmonary arterial hypertension. However, 50% don't. So you can see that even within the pulmonary vascular community, there is a disagreement as to what the best right ventricular, what the best agent to support the right ventricle is. So I think that's an important aspect to bear in mind, that no one can be absolute as to what the best way to support the right ventricle is. And in a community of pulmonary arterial hypertension experts we would hope that they have the answers, we don't have the answers, and it's 50-50 chances to whether or not you get dobutamine or something else.
And then going along with that squeeze phenomenon is the topic of afterload, which we've kind of addressed. In the emergency department, we have very few agents, but in the ICU setting, you have sildenafil, Flolan.
Yeah, so but I want to touch on this as well, seeing as you bring it up, is that the use, say for example, and this is specific to pulmonary arterial hypertension and pulmonary vascular remodeling in that setting. Sildenafil improves outcomes in pulmonary arterial hypertension, but lowers the pulmonary artery pressure by maybe 3 millimeters of mercury. It improves pulmonary vascular resistance, and it lowers pulmonary vascular resistance, at least when taken long term, when taken in 12 weeks in the super trial, etc. It will lower pulmonary vascular resistance, but it doesn't change pulmonary artery pressure a whole lot, if at all. And because what you see is, as you know, pulmonary vascular resistance is mean pulmonary artery pressure, is determined by mean pulmonary artery pressure and cardiac output. So what you see with the use of sildenafil chronically over a 12-week period is that the cardiac output goes up, and through phosphodiesterase 5 inhibition, you get an improvement in cardiac output. I think in the acute setting, even with Flolan or Remodulin, which is what we use primarily, again, you don't get that much of a difference in pulmonary artery pressures. And the reason is probably twofold. One is that it doesn't change pressures very much. The other is that when it does lower pressures, then your cardiac output improves. And what happens when your cardiac output improves, such as with your systolic heart failure, when you have guys coming in with systolic heart failure whose blood pressure is, 80 over 40, and you start them on something to support their left ventricle, their pressures start coming up. And it's the same actual concept with the right ventricular performance. When you start prostacyclins on someone with right ventricular failure, the pressures will actually initially go down, and then as the cardiac output improves, the pressures will come up because the right ventricle is now working better, so it can actually mount a pressure. So the pressures don't actually change a whole lot. Pulmonary vascular resistance changes, but the pressures don't. So I wouldn't use sildenafil in the acute setting in this. But if you are trying to lower pulmonary artery pressures, nitric oxide might be useful. Again, that would depend on intubation and so on, and you go from there. But ultimately, this guy has so many things going on that I think the best thing you can do is what you're proposing, which is throwing the kitchen sink at him, trying to get his oxygen up, trying to get his carbon dioxide down, trying to support his right ventricle, trying to manage his fluid output so he's not overloaded versus underfilled, and trying to make sure that he's not ischemic by adding on, or at least actively ischemic by adding on heparin and so on. So I think you're doing a great job. I think you'd have to really talk with the patient and their family and explain the seriousness as to what's going on. In the pulmonary arterial hypertension literature, intubation, people who are intubated and started on inotropes have an almost 100% mortality. So I think it's important to let people know that.
And so in this particular case, I had a long discussion with the patient. I was very concerned about his risk for peri-intubation arrest. I was reassured by the fact that I'd had him in the emergency department for 3 to 4 hours. He'd been initiated on heparin. His oxygen saturations gradually improved to 85, 86% continuously with the CPAP support. He was conversant, and when he was aware of the risk of deterioration from doing nothing versus the risk of deterioration from intubation, he actually preferred not to undergo intubation because he felt comfortable with the transport. And there was some degree of argument about that, but I elected not to intubate the patient, and he was transported ground on CPAP, arrived uneventfully to a tertiary care facility where he was not intubated. And they'd continued him on CPAP. Approximately 2 days later, his renal function had improved to a point where he could undergo CT imaging, and he was found to have a large saddle embolus. And so it ended up being most likely a PE superimposed on a setting of morbidly obese patient who had probably obesity, hypoventilation, obstructive sleep apnea. And I haven't been able to see any follow-up studies on him to get a better diagnostic picture of what other contributors he had to his presentation. But I was incredibly hesitant with almost every decision in this case, and it was a really difficult case for me to address, knowing the limitations of echocardiography in the evaluation of right ventricular dysfunction. We all want it to be a PE, and you want to see an image like this, and you want them to be, just a little bit hypotensive so you can justify lysing them before they code, and all of those things. They rarely come together, and more often you're dealing with suboptimal images, making vague interpretations with limited history, and I think it's a really difficult thing to do. And I think shared decision-making is key.
Yeah, no, I think you did. That's a really impressive job you did here, and clearly a very critically ill guy. And I think you did a great job in turning him around and involving him in the decision-making process. And I am surprised that he did have a saddle pulmonary embolus. I wasn't expecting that, especially with your images. So it's just a really tough case, and I think you did a really nice job. Thanks for sharing it with me.
Yeah.
Is this mine?
I poached this off the internet somewhere. That might be yours. That might be yours.
All right, Echoholics, that concludes another episode. Thanks to John Ryan for spending time to educate us on some pulmonary hypertension topics. If anything, this case illustrates the difficulties of real-world practice where our images are not often optimal, especially in critically ill patients. But some things we can take away are that the 60-60 sign, while it isn't perfect, is the best we have as far as diagnosing acute pulmonary embolism when we're limited to echocardiography alone. There were some thoughts about vasopressors in RV failure, with John Ryan recommending epinephrine or dobutamine, as well as avoidance of milrinone, but there is a disconcerting lack of consensus among the pulmonary hypertension experts as to ideal choice in this scenario. Lastly, this was a good example of shared decision making and how that can help improve the care of your patients and tailor it to their preferences. And that's all for this episode. Thanks for tuning in, and we'll see you next time.